kia ora koutou, ngā mihi o te rā, tu tau mai runga, tu tau mai raro, tu tau mai roto, tu tau mai waho, kia tau ai te Māori tū, kia tau ai te Māori ora, tū te whakamaua, kia tīna, homi e hui e, tēnā koutou katoa, ko Justin Richards toku ingoa, ko ho te academic lead mō Ihi Aotearoa, ko hohoki te ahu nuku, Kori tinana me Hauora mō te renga waka. Nō reira, tēnā koutou, tēnā tātou katoa. Welcome everyone to our inaugural Te Hau Kori seminar series. We've got Simon Rosenbaum here with us today. It's our first one for Te Hau Kori. This is something we're going to make a regular feature, so we hope to see all of you again and more in the time ahead. We might even get to a point where we can book a bigger lecture theatre, hopefully. But Te Hau Kori is a centre that's been formed up at Victoria University as a partnership between Sport New Zealand, Ihi Aotearoa and Vic Uni Te Renga Waka. And it's also a partnership between Tangata Whenua and Tangata Tiriti in that all our positions within the centre are duplicate roles representing both sides of the treaty. Our mission at Te Hau Kori is around driving research and workforce development, which fills the gap that we see currently in New Zealand but also internationally in terms of physical activity promotion. I'm excited to finally welcome Simon Rosenbaum, Associate Professor Simon Rosenbaum, here to Wellington. Thank you so much to Ruth for getting him to New Zealand. Thank you to Gregor for getting him to Wellington. And thank you also to Julie and Nicola for their support for this initiative and for this seminar series from Ihi Aotearoa, from Sport New Zealand. I've known Simon now I think we met each other in 2012 at a little seminar. And we hit it off then. And in that time, he's definitely cemented himself as the global expert, the go-to person when it comes to physical activity and mental health. I've watched on from afar. I've tried to keep up with him. It's quite a feat. I've watched on from afar as he's just done some amazing stuff. And I'm really excited today. He's just promised me on the walk over here that he's presenting a whole bunch of stuff that I've never seen before. So that's exciting for me. And I'm looking forward to hearing about some of the remarkable work that he's done and what he's achieved as he shares his thoughts with us today. Thanks, Simon.
Turn this microphone on. I know it's a big deal when Justin's wearing pants and not shorts. So yeah, just in general. Okay, look, thanks so much for having me. That welcome. Firstly, I'm from Australia. I'm sure a lot of people have been there. It's not like I'm far away. It's really important that we acknowledge the traditional custodians of the land in which I come from. That's the Gadigal, Bidjigal people. And it's just being here, I realise how far Australia has to go and how sad it actually is, the context at the moment. And if you're following Australian politics, the referendum that's taking place, and it's going to be an ugly war. So I think this is really important, and thank you. It's just really... It's really just motivating and to see what's happening here in New Zealand. Okay, so what I'm going to talk about today is a bunch of work that we're doing focusing on workforces. So I'll present a little bit of evidence around why is physical activity so critical for mental health. Apologies if there's any mental health clinicians or professionals in the audience. There's only 1 or 2 slides of very basic mental health related stuff, and then we'll go into sort of what's happening going forward. And I'll talk a bit about a global perspective around how we're merging these two workforces, including in humanitarian and conflict affected settings, and the sort of real opportunities that there are for sport, physical activity and mental health working together. So the first thing that I think is really important, we sort of use this a lot, is just talking briefly about the difference between mental health and mental illness, because they are different things, they exist on different continuums, and not to get them confused. So essentially on one axis we've got mental health, so the idea of optimal mental health, poor mental health. At any point in time we're somewhere on that spectrum. I haven't slept, I'm a bit jet lagged, I do get quite anxious, so you could put me down here. Yeah, I don't have a mental illness, but right now a bit stressed, a bit anxious, yeah? Likewise, you could have someone with a serious mental illness, could be schizophrenia, bipolar disorder, PTSD, whatever it is. So they've got that serious mental illness, but they're in treatment. So it might be whatever that treatment is for them, talking-based therapy, a combination, talking-based therapy, medication, physical activity, whatever it is that's important for that person at that point in time. Now, the important thing with this, when we think about physical activity, is that no matter where someone is, no matter which quadrant, there is a role for physical activity as part of treatment. Okay, so if we've got someone down here, that sort of serious quadrant with a diagnosed mental illness, experiencing poor mental health. They could be in a hospital, they might be in an intensive care, mental health intensive care unit. There's still a role for physical activity. But we just have to make sure that the resources and the support that we provide to people matches the need where they are at that point in time. And that's where we're failing. Yeah. Likewise, all the way through to here, where someone optimal mental health, no mental illness, general stress, general anxiety, well-being. Justin's done a lot of work in that space. Physical activity has a role to play there as well. Now, I've got a whole lecture I do using social media slides or pictures, and I think this one just sums it up perfectly for me. Someone just saying, I'm sick of people who don't have a mental illness saying I should just exercise to help my mood. 90% of the time I don't have the energy to shower or make food, so how the F am I going to exercise? Just shut up. And even yesterday I had an interview with a journalist. There was a new review that's come out, and they've concluded that physical activity is 1.5 times more effective than medication. I don't know what that means, but it's a terrible message, and it's a dangerous message that we send. And one of the reasons it's so dangerous is the idea of shame and guilt that it lumps onto people who are already experiencing these barriers, these challenges to get active. So I would say that this is not a failure of that individual, it's a failure of the system and the support that we're providing to support that person to actually engage and to be physically active. So with that idea in mind about matching the resources to the level of need of the person we're working with, this is a pyramid that we've been working on together with Justin and a colleague, Anna Farello, in the UK. And this is based on the humanitarian mental health pyramid. So I'll just explain that briefly. In conflict-affected or humanitarian areas, mental health care is divided into 4 layers. At the top of the pyramid is what we call specialised care, so that would be a psychiatrist, and down the bottom is basic needs. And so we're using that pyramid, but we've replicated that thinking about physical activity. Yeah, but this applies not just in a refugee context, but also in places like New Zealand and Australia. At the very bottom, we're talking about ensuring appropriate access to equipment and infrastructure. That's the bare minimum. Yeah, that's not going to work for everyone, but it's the bare minimum that we need to be doing. And there's plenty of guidelines, WHO guidelines that recommend people living with a mental illness at very least need to be provided with supported access. Yeah, so this is level 1. Now, level 2, we consider being community sport, community physical activity programs. So that might be park run, it might be a local gym, it might be working with the National Olympic Committee through those sporting committees, just general programs that are for the general population, not targeted. Okay? What we need to keep in mind here is that these, there's this word, this idea of psychological safety, and that these programs are likely not psychologically safe for many of the people we're trying to interact with or we're trying to support. Yeah? So simply giving a gym membership is not going to work for a lot of people. There's a lot of barriers there. That's when we move up the idea of focused, non-specialised programs. And this is where we might have, for example, coaches or physical activity advocates or physios trained in mental health first aid or other programs like that. There's a good example of Team Up, which is an initiative out of Europe, training sports coaches in basic what they call psychosocial programming, so that they can create those environments to engage people experiencing distress or experiencing poor mental health. Then at that top of the pyramid, we'd see specialised support. So again, that could be physiotherapy, exercise physiology, whatever it is, but that could be someone living with severe, persistent mental illness. We can still help that person. Yeah, we just need the right resources. Not everyone will need this, but we need to know it's there, and we need to acknowledge that people will move through this pyramid in different ways, and we need to have methods that we can catch them and filter them back in. Yep. Now, I've got a bunch of QR codes on these slides, but don't worry, because I can make them available to Justin as well. And if there are any questions as we go, please just interrupt. All right, what do you see with this picture? What's the first thing that kind of jumps out? So the separation, for starters. Yeah, so we've got mind on body, and I think this is a really good analogy for the health system in general. We've got the psychiatrist, psychologist, everyone down here working on the mind. Then we have this body, cardiologist, GP, endocrinologist. Now, the reason this is so important is that people living with a mental illness will die up to 25 years earlier than the general population. Now, that gap in life expectancy is not due to suicide. It's overwhelmingly due to premature, preventable cardiovascular disease. Okay? So there is this enormous gap in life expectancy, which has been identified as a scandal and a human rights issue. And this idea that if that was affecting another population that didn't carry the same stigma as people living with mental illness, there'd be outrage and we'd actually do something about it. Yeah. The other thing that you'll notice here is that premature cardiovascular disease and that obesity. And I'll go through that. But in terms of the evidence is very, very clear that if someone is living with a mental illness, regardless of what that diagnosis is, they are likely to experience, they're at significantly higher risk of experiencing cardiovascular disease. So the question that this asks is, well, what is routine mental health care? And the important thing that I'll stress today is I'm not saying that existing mental health treatments don't work or are not needed. That's absolutely not the message. The message is that given the evidence we have and what we know the role of physical activity is, it should be an embedded, integrated component of care. That's what all the evidence tells us. And so it raises this question. This is a picture I took in Bangladesh, in the biggest refugee camp in the world, the Rohingya refugee camps. This is a game called Chinlon that's quite common in Southeast Asia. It's a crazy game. It's like volleyball with your feet. It's one of the most athletic things I've seen. A question being that given what we know about things like this, is this routine part of care, of mental health care? Now, I spent 6 months working with a UN agency in Bangladesh as the mental health officer. So we had 24 staff who were social workers, psychologists, and when we audited what they were doing in camp, about 30% of everything they did was organised sport. But they've got no training, no understanding why, they just know it works. And so they might have some balls, chuck some balls, and that's it. Get going, and that's sport. So this is already happening. It's already part of what they're doing, but it's not recognised by funders in the same way, and that's slowly changing. And it's not given the same level of resourcing that it should, given the evidence we have. I'll just quickly run through again some of the evidence around the poor physical health, and I'm sure everyone's familiar with this, the big 4 risk factors, CVD. We can just cross out cardiovascular disease and replace that with poor mental health. Yep, and the evidence is very, very strong. This was a review led by Joe Firth in World Psychiatry a couple of years ago, looking at the relationship between these risk factors and some of the common disorders. So ADHD, anxiety, depression, bipolar, and psychotic disorders. And this is open access. The strongest relationship was exercise and depression. For exercise as a risk factor, but also smoking as well, which is unsurprising. And increasingly, we're seeing interventions trying to tackle these together. Things like nutrition, physical activity, because it goes hand in hand. Now, this idea about the physical health of people living with mental illness, it's such a critical international issue that there was a Lancet Commission in 2019. So for those unfamiliar with Lancet Commissions, they're done on things that are deemed of being on issues, deemed of being international significance. So there's been commissions on back pain, climate change, opioid addiction, really, really important stuff that affect people globally. And you can see that quote, protecting the physical health of people with mental illness should be considered an international priority for reducing the personal, social and economic burden of mental health conditions. And I'll walk you through the commission. There's 4 key points. 1, any mental illness is associated with cardiovascular disease, up to twice the risk. Okay, so there used to be this idea this was only things like schizophrenia, but it's actually not true. It's across the entire spectrum. Interestingly, we know there's disturbances in these risk factors from illness onset. And in some instances, there's some exciting work happening from a prevention point of view. And there's a race on at the moment among the big data companies, Google, for example. Can your wearables detect that you're going to have an episode of poor mental health before you do? And that sounds a bit crazy, but if you think about what your phone knows, it's got your social interaction, it's got your sleep, it's got your physical activity levels, it might have your nutrition if you're feeding that. It's got all these things that we know are disturbed as soon as people are seeking care. And there's even some interesting stuff coming out now looking at even at ultra high risk, people that are at high risk of mental illness, there's already disturbances in some of these. One of the strongest examples we have is post-traumatic stress disorder, and the trajectory of the illness can follow patterns of physical activity. So we see that withdrawal, we see that decline in activity, and it raises a question about a sort of safety net. And if we can detect changes in those things and capture people early and intervene before physical health deteriorates, what happens to the trajectory of the illness? Now, of course, it's not going to cure every episode or every case. That's not what we're saying, but it can make a significant difference. And for some people, it may be enough. The other recommendation here, and this is section 4, which I know really well because I led it, so it's very, very clear, the recommendations, that mental health services should provide sufficient access to supervised exercise programs. And we're following up at the moment. We're doing an update to the Commission, being very clear about what that actually means, because that wasn't articulated. And that pyramid will be used to say, look, if you just have a cupboard in the hospital where you've got someone, with an elastic band, that's a great start, but it's not enough. Because it's not enough, it's not what's needed, and it's not in line with the evidence around what we need to do to help people actually participate. And finally, the idea that physical health services need to be prevention focused. So physical health deteriorates rapidly when people come in contact with a mental health service. And I'll give you one example, early psychosis, which is a really important issue. Young people experiencing early psychosis are often prescribed medication, antipsychotic medication, that is important. It absolutely is needed from a mental health perspective, but there is a rapid dramatic effect of that medication on physical health. To give you an idea, on average, young people will put on somewhere between 7 and 9 kilograms in 12 weeks. Okay, but if you just think about what that actually means, and if a young person comes in contact with a mental health service, they take these drugs that they absolutely need, but suddenly they don't recognise themselves in the mirror, and their physical health has rapidly deteriorated. We've shown in Sydney that if you intervene at day 1, so at the point of initiation, as soon as that young person comes in contact with the health service, you can prevent that weight gain from happening. And we published that data, which was then enough for the district to reinvest about $1 million of recurrent funding and roll that out across the entire district. So we can, again, this isn't a gap in our knowledge. We know what to do. We just have to resource these things appropriately. Now, a quick summary of the evidence, just focusing on depression here. This was a piece in the New York Times that was covering a paper that Justin and I were involved with. It was a big review in 2016 led by Felipe Schuch in Brazil. And this was the article in the New York Times, super problematic. If you just look at this, maybe you'll see why this is really common. The messaging, the way the media talks about this is not helpful. So having a picture of a beautiful model running into a new dawn, it just sends the message, hey, get out of bed, go for a run, you're cured, you're fine. Yeah, and that's obviously not the case. So we've got to be really careful about how we actually sell this. This is probably a safe audience, so I can point out that top quote. I've been in trouble before with that in the US. I had a room that just went silent. But again, you can see that same thing, unable to get up in the first place. And there's always, whenever there's coverage of this, people are just saying, piss off, like this isn't helpful. Now, this has been updated just 2 weeks ago. This came out. This is another meta-analysis in the British Journal of Sports Medicine. What's really interesting since 2016 is that the number of trials has nearly doubled and the effect sizes have remained constant. So in other words, the robustness of this data is just getting better and better. Yeah. Likewise, Felipe led a great review that he published in the American Journal of Psychiatry in 2018, looking at physical activity and prevention. And from a public health perspective, this is super interesting. What that showed was that if we shifted population levels of physical activity by as little as 60 minutes a week, now that's per week, not in one chunk, it can be broken up, so it's 60 minutes a week, we would prevent somewhere between 12 and 17% of incident cases of depression globally. Yeah, now that's an enormous, if you think about the burden of disease of depression, the impact there around prevention and focusing on prevention measures that include activity is absolutely critical. Now, this is probably not relevant for a physical activity audience, but I'll just go through it quickly. The 4 domains of activity, which everyone here will be familiar with, but in case there's mental health professionals in the audience. What we've got is 4 different types. So we'll call this leisure or recreational physical activity, occupational physical activity, transport, and I think this might be one of Justin's photos, household activity, that's not me either. They're not all equally associated with mental health outcomes. So when we're talking about promoting mental health, we've got to be really aware of that. Leisure and transport are the ones that we seem to see a bigger relationship with. Now, that's not a surprise, and to me, that's related to privilege. It's related to having the social capital, the financial capital, living in a safe environment, having footpaths, having shoes, not having caring responsibilities, so you've got free time to be able to participate and engage in activity. So I don't think it's a surprise that high levels of occupational physical activity don't have the same benefit. And so we just need to be aware of that when we're talking about promoting physical activity. And there's some also really fantastic data locally here from New Zealand. I think Ollie's here somewhere, who I haven't actually met before, but nice to meet you. So there's some great data here in New Zealand looking at the idea about these different types as well, and the impact of socioeconomic status and some of those factors that we know are so critical. Now, this is a really recent paper that was led by Stuart Bella. It only came out a few weeks ago. He's an academic in Australia, Wollongong University, does a lot of work upskilling sports workforces around mental health. And he developed Ahead of the Game, which is a fantastic initiative. But this is a really important piece that just goes a little bit deeper into some of those questions when we're talking about promoting activity. The factors, what they've called the contextual factors that are related to mental health outcomes. So some of the things to consider is what the type of exercise we're doing, when and why it's happening, so those domains, where, we've all heard of blue gym, green gym, being outside, being near water if you're lucky enough to have access, who you do it with, so the social interactions, and then importantly, how it's delivered. And we know this is so critical. And the how relates to really important work that leads on to where I'm going to take this, but this was Justin's PhD work, which I'm sure hopefully people are familiar with. I think it's one of the most important pieces of data we have in terms of the mental health impacts of sport programs, particularly in low resource contexts. So this is Justin's work in Uganda, essentially evaluating a football competition. And I won't go into detail given he's sitting there, but essentially what it showed was that having untrained or poorly trained coaches actually led to mental health outcomes being worse among the participants. And this is such critical information because when we talk about sport, physical activity, we can't just say, hey, here's a ball, go and do something. We've got to think about how do we upskill those workforces and do it together. Now, that's where I think there's real opportunity, and what I'll sort of talk about where we're going with this work now, particularly overseas. So how can we actually... First of all, are there any questions? I'll take it. Any... We're all still mostly awake. Yeah.
You were talking about work, and I've heard it before, how people with serious mental illness actually struggle. So how do you then overcome that barrier?
Yeah, so it depends where they are. Oh, sorry. So the question was if people living with serious mental illness experience barriers and it might be hard, to get out of bed, how do we actually engage and motivate? So it depends on the context on where they are. So, for example, if you've got someone hospitalised, there are specialist mental health physiotherapists working in hospitals who are extremely well skilled in actually providing those interventions. If you've got someone in the community, there's ways of engaging with a community mental health team so that it's done together. So that there are ways that we can do this. Yeah, it's actually not very novel or exciting. It's quite simple. It's going back to basics, but ensuring that we can actually meet that person where they're at and understanding what their barriers are and how we can overcome them. Yeah, I can send some more specific stuff after this. So in terms of these professionals, what do we need to do to bring them together and what can happen? And so there's two ways that we're thinking about this. One is the mental health professionals. Yeah. So physical activity is typically not part of a psychiatric or psychology training program. Yeah, increasingly that's changing, and we're seeing great examples in places like Scandinavia where it is happening. But things like healthy eating, physical activity, basic assessment and counselling. As a psychiatrist, if they've got 30 seconds to dedicate to this and they can ask one question to assess, is that being done? So there's ways that we can do, but that needs additional training. The bilateral referral pathways are so critical. We need to make sure that the mental health workforce understands how they can refer and get support from the sport physical activity workforce and vice versa. On the other side of things, if we talk about sports coaches, physical activity professionals, they don't have training in mental health. Yeah, so if we want that to be safe, we need to find a way that they can be upskilled as well. Now, there's two courses there. One mental health first aid, and the other PFA, which is psychological first aid. Now, these are really practical skills that provide really concrete skills on how to navigate safely through someone that might be experiencing mental health issues or suicidality. The difference between those two is that mental health first aid is typically focused on high income, high resource settings. That's where it was developed. PFA is what's used in humanitarian, low income settings. But essentially it's the same principles. It's getting those lay people and providing some basic skills around mental health and well-being. Now, this work in the past sort of 6 months has come a really long way. So this is the first time I've actually been able to speak about it, which is exciting. So this has been led by the Olympic Refuge Foundation, together with a colleague, Dr. Leslie Snyder, who developed PFA for WHO back in the late 90s. Now, in September, we went to Paris, and we got a group of sports coaches working in Paris, and we ran what we called PFA Sport. So that was essentially just training them in psychological first aid, but it was adapted and tweaked for a sporting context. Yeah. Then a few weeks ago, we were in Moldova doing the same thing, but the following day, we had the mental health professionals come in. So that acronym, mental health psychosocial support. So that's just what's used for broad mental health professionals in humanitarian contexts. So day one, we did PFA, so psychological first aid for the sports coaches. Day two, we got the mental health professionals in. And then at the end of the day, we actually put them together. And we said, right, who's doing what, where, and how can you link up? And we found some really fantastic initiatives. For example, the Squash Foundation in Moldova was running programs for Ukrainian refugees. But they had absolutely no knowledge of the mental health workforce, how to refer, how to get help. Likewise, we had the mental health workforce saying, yeah, we'd love to have support with sport and physical activity, but we don't know how to do that. And so actually putting them together. The next step, and this is what even more excited, next week I'm heading to Poland. What we've got in collaboration with WHO is we have one sports coach, a senior sports coach, and a senior psychologist from every region in Poland. So there's 16. They're coming together and we've got a 3-day training of trainers, with the idea being that we'll train the coaches and the mental health professionals together, build those pathways, understand what's needed, and then they will go back into their regions and we'll continue to provide support. Now, some of the interesting stuff that's come out is, well, that the physical activity or sport workforce doesn't have the skills or the confidence. But that's where if you team them up with the mental health workforce, they can get ongoing support and development and supervision. And likewise, the mental health workforce can get ongoing support and supervision from the physical activity sports. So there's lots of opportunity there, and I think that this is not just relevant in that context, but actually can be applied in Australia, here in New Zealand as well. Any questions on that? Yeah.
On that, the Polish example, training up the mental health professionals so they can deliver physical activity, just so that they better understand.
I was wondering what they were. That's
Some of the dice.
Hello. Okay. In the
Just feels pretty weird.
in the Polish example, is it about training up the mental health professionals so they can deliver the physical activity intervention, or is it more about so that they know where to refer people on to?
Yep.
Not them delivering themselves.
Good question. I think where we have to start is recognition that this is important. Yeah. So we have some mental health professionals, and this is the same in Australia in hospitals, and probably the same here. And we've published data on this looking at the relationship between psychiatrists' own fitness, their own physical activity levels, and their willingness to refer patients. So that culture aspect is so critical. Where I think we need to start is at the very bottom, which is so that all staff have some foundational knowledge and recognition that this is important, this is part of their job. The way we're evaluating this is a questionnaire we've developed. One of the items is I strongly, I agree that promoting physical activity is part of my job. And what's interesting is when I do that with the MHPSS staff, we often, at the start, they say no. And then very quickly they say, okay, yeah, this is part of our job. So there are some that are all over it and they do it. There are some that don't. So we need to start at foundation, present the evidence, show this is why, and then work through how do we get them there. Yeah. So I think it's probably the answer is both, and we'll get to the point where the ones that are really engaged will want additional training. co-delivering interventions together. If you've got a psychologist, social worker, whatever it is, and the sports physical activity person doing the sessions together, that's where we'll ultimately get to. It's also a pathway into traditional care. And what I mean by that, the Ukrainians are a great example. There's really high levels of stigma among that group towards mental illness. What we've heard is that they're not accessing services. They just won't come. But they're turning up and playing sport. Apparently in Moldova, a lot of them are sleeping inside their cars at the Oval. That's just where they're camping. So why not, instead of trying to get them to mental health services, put the mental health services where they are and where they're at? Yeah.
Sorry, Simon, just to go along with that, is there any use in trying to explain what physical activity is to mental health professionals, or do you not bother with that?
No, of course. That's part of the training we do. Like what I did here, a lot of it was some of this stuff, but really basic. What is sport? What is physical activity? It's not just going for a run outside. Yeah, so that's a big part of it. So we talk about getting mental health literacy among these guys. We need physical activity literacy in these guys. Yeah.
What is the role of in describing what physical activity is? The role of fun and enjoyment as a way to engage in.
You might have my next slide,
Oh, sorry.
but in case I took it out, absolutely when I'm talking to mental health professionals and when we cover the evidence, the critical thing is enjoyment. It's the only thing that matters for long-term adherence. So we've absolutely got to make it fun and think about that as the critical part. There's some really interesting work in Norway. They've done some great stuff around 4 minutes. Are there any Norwegians in here? So they've got this thing around 4-minute intervals that they do, and they're obsessed with it because, of course, it improves fitness better than steady state exercise, of course. But who cares if no one's going to do it? But they have this really strong thing that the patients at the psych hospital have to do that before they do what they want. Which I just can't understand, because all the data we have and the importance around autonomy, self-determination, building that, people exercising because they feel it for themselves and they want to. That's the way we're going to change behaviour long term. So the enjoyment piece is probably, when I'm doing this part, the most important thing. Yeah. Any mental health professionals in the room? This was a review that we published recently, led by Dr. Grace McEwen, who was one of my PhD students. Really simple flowchart for psychiatrists saying, right, if you've got 1 minute, here's a tool you can use, physical activity vital sign. If that's all you want to use, screen on that. Above or below 150 minutes, refer. Take steps. If someone is flagging that they're at risk, do something about it. The same way you would around blood pressure, all the other things that are being measured. And then if you've got a bit longer, we know some psychiatrists are interested in this. They'll prioritise it a bit more. There's other tools that can be used that take a bit of time. A couple of just key points before I'll open up for discussion. This is again from Grace's thesis. And this is around the importance of peer workers and lived experience. And for me, this is probably the most exciting thing evolving in this work going forward. So Grace's PhD was with emergency service workers with post-traumatic stress disorder. And we recruited a bunch and their family member or partner. So they got to nominate one person. And we put them together in a private Facebook group. And we had peer workers who had lived experience of both being an emergency service worker and of experiencing PTSD. And they were like our health coaches. And this was an infographic on a paper that Grace published that we can't see, looking at the difference between that expertise by training, which is us, and that expertise by lived experience, and ensuring that we absolutely prioritise and value that lived experience equally with the technical expertise. This was super interesting. On the Facebook group, people would post, I'm having a bad day. And before we had a chance on, the peer workers, the participants would jump in and they'd be on the phone having chats with each other. Now, we've got to make sure that's safe. We need to look at the skills of that peer workforce, and there's a lot of work happening there. But I think when it comes to physical activity promotion, that lived experience is so critical, because they can say and do things that we can't, and in a language that we don't have. So I think it's really, really important. Enjoyment, this comes to the enjoyment factor. So these were 2 animations we put together, one in Rohingya, these are the English translations, and one in Arabic targeting Syrian refugees in Lebanon, based on some work that we've done in those contexts. The story here, and this was based on the work we did in Bangladesh, was a young girl talking to her mum And a mum describing how sometimes she feels sad, her daughter saying there are things that we can control, things we can't control, and then talking through and communicating some of the stuff that we found when we did interviews with members of that community. The interesting thing there was, we were trying to understand the community's views around physical activity, mental health, coping, and this word that kept coming up was tension. And it's a really common idiom of distress in other cultures, this idea of tension. And time again, both men, women would tell us that when they were able to participate in physical activity and sport, there would be this sense of mind fresh. And I just really loved that word and that way of sort of describing it. And so again, we've used that to try to advocate within the mental health funders in the camp, how can we create opportunities? Very deliberately focusing on women and children because they are often ignored and not in the picture when it comes to sport. Yeah, the able-bodied young men are going to play. They're going to find a way to do it. We actually need active, assertive interventions to reach these groups. So the way I sort of think about it is, how do we get physical activity embedded as a specialised service? So coming back to that pyramid, how do we get it through every layer of that pyramid? And that applies not just in Bangladesh, but here in New Zealand, in Australia as well. And there's three things that we've written about: culture, training, and I've spoken a lot about training, and also infrastructure. Now, I won't play that video, but this was in Bangladesh, in Cox's Bazar, after we did some training for the mental health staff there, and this was their idea. We had a drone and we went out onto the beach. It's the longest sea beach in the world. They drew a brain in the sand, and then they were doing push-ups in the brain as the drone flew over. And that was entirely their idea. It was how they wanted to sort of remember what they had taken and how they had thought about this sort of what we were doing. The infrastructure is so critical, and I'd also include referral pathways in that, and the opportunities for those training. Without some level of infrastructure, we can't expect much to happen. Walking groups will get us so far, but it's not enough. All right, this brings us to the final point, which I'm really excited to be able to talk about as well. Addison Road Community Centre. Has anyone been to Addi Road or heard of Addi Road? Justin has. Okay, Addison Road is this incredible place in Sydney, in Marrickville. It's a community organisation that provides essentially what they mostly deal with is food insecurity. So they've got a food pantry, but they've got about 60 social services on site. Gender-based violence, Marrickville Legal Centre, Indigenous health services, you name it, it's there. Yeah, I've always had this sort of dream. I've spoken to Justin plenty of times about a not-for-profit gym, or like an exercise space that was safe, welcoming, finance wasn't a barrier, we could support people to come. Addi Road was the perfect place to do that because people are already there, that co-location of services. So in December 2021, they gave us a building at Addi Road, which was fantastic. So a few months later, we had this idea, we need a bit of a launch and we need some artwork to go in the back of the gym. Now, this is Moz Azimbatar, who's a Kurdish refugee who was detained by the Australian government for 8 years. He was locked up without charge. Him and I are the exact same age. So while I was studying and doing my PhD, he was locked in a room. He was then in the Park Hotel, made famous by Novak Djokovic when we wouldn't let him play tennis. And that brought a bit of international attention to this issue. Now, Moz is an artist and he didn't have access to any painting supplies while he was in prison. He's also an Archibald finalist now, which is amazing. What he did have, though, was a toothbrush and coffee beans. So that's how he used to paint. He used to do his artwork with a toothbrush and coffee. So that's Moz. Then we have Maura, Farhat and Farhat from Afghanistan. They fled the Taliban last year, came to Australia, and of course ended up at Addi Road doing a lot of work there because that's sort of the power of Addi Road. So at the launch event, they got together and painted this mural with toothbrushes. And that's now in the back of our gym. So that's what it kind of looked like. That's Dr. Grace McEwen, who's been working with us. This I took a couple of days ago, is what it looks like now. Now, the past 12 months we've been there, we haven't seen a single person. We haven't provided exercise to a single service user because we've gone through this really slow and deliberate co-design process. Okay, so we want this to focus on women and women from a refugee background who don't have access. So it's entirely free. What we've done is we've interviewed service users and service providers for 12 months. We filmed those interviews, we analysed the transcripts, we then made a movie out of those interviews, played that movie back to everyone involved to make sure that we had captured everything, and now we're writing that up as a paper. But it's given us a very clear roadmap around what we need to do to make services like this work, safe and accessible for those groups we're trying to reach. The second phase of what we did, and I can't stress this enough, was we've just finished our staff intervention. Okay, and we did this first at South East Sydney Local Health District, and we published this data with 212 staff from the mental health service in Sydney. And before we rolled out this exercise lifestyle program to patients, we took, again, another year and we just provided it to staff with the idea of trying to change the culture of the mental health workforce so that they understood what it was that we were doing, why we were doing it. We're not just going in saying everyone's overweight and do some exercise, which is a terrible message. I'll give you a quick example of the impact of that staff intervention. I had a male nurse who had been there for 30 years, and he got really frustrated with me being there talking about this stuff, and he used to just get quite angry and say, look, piss off, if I wanted to be a personal trainer, I would have been a personal trainer. Like, leave me alone, I'm a nurse. As part of it, we gave staff Fitbits. And so it took about 4 weeks before he would come up and say, can I have one of those Fitbits? Like, yeah, of course you can. So we gave him one. So he wasn't formally included in the data. By week 10, he was coming and showing the dietitian what he'd made for lunch. So everything had changed around him, and he was kind of forced to jump on board. He then started walking and talking sessions with the clients he was working with. So it completely shifted. Now, we're not going to have any sustainable change within mental health services, and we've seen it time and time again, unless we change the culture within the staff and beginning with the staff. So, my advice is if you've got access to a pilot or somewhere to start this, start with the staff as best as you can. This is my last slide. Psychological first aid has 3 principles: look, listen, link. It's really simple. We've now adapted that for the physical activity stuff. So look, listen, link for physical health. So this is how we're training the mental health professionals. Looking for signs of declining physical health, weight gain, excessive sedentary behaviour. Listen and assess, the idea that what gets measured gets done. So if we're not measuring this, how can we expect anything to happen? There are tools available that have been specifically developed, and this one was, huge role from Justin involved in that. And then linking with local services, mental health professionals should be providing lifestyle counselling, or at the very least knowing how they get access to it and supporting that referral. Clear referral pathways, physios, EPs, sporting clubs, teams across every level. Thinking about peer support and co-delivery alongside with people with lived experience. I'll leave it there. I'm really happy to take any questions, and thanks again for having me.
Questions, anyone? I'll throw this at you.
Great presentation. Thanks, Simon. You touched on a few differences. You talked about refugees, talked about different gender. I would be interested in the life course approach to mental health using physical activity. Are there any recommendations from your end, observations in regard to barriers? I would assume that probably working with adolescents is quite different, working with middle-aged people or the elderly, retired people. Any work being done there?
Yeah, absolutely. So starting with elderly people, there's a lot of work now looking at falls prevention programs, the mental health impact of those falls prevention programs. Because essentially, if we're getting people moving, looking at balance training, the social interaction, all those things that are related are really important. The other aspect around that is strength training. We really underutilise resistance training as a modality, particularly for women, particularly for older adults. We're doing, sort of powerlifting with refugees as a strategy. Resistance training is hugely empowering, can have a really big impact. It needs to be supervised, needs to be safe, but it's really underutilised for older adults. There's also the other benefits around bone mineral density, diabetes, insulin resistance. In terms of evidence around mental health and older adults, again, Felipe, who's sort of the king of reviews, published a great review on older adults' depression and mental health, a big meta-analysis. So the evidence is clear, the effect sizes are the same. I think where my work with older adults is moving into the online digital stuff. So things like Facebook, they're well engaged with Facebook. We've just finished a trial. We still had 40% dropout, but that's low for online interventions. But a significant impact on psychological distress after 10 weeks, all virtual. Yeah. So, great.
Any more questions?
I just wondered if you'd done any work on sort of formalised as opposed to informalised physical activity, and certainly for young people, whether actually making it more formalised turns people off.
Yep, absolutely. I think the critical thing is how do we get people in the door? So whether it's formal, informal, and I guess what we also mean by that, so different, are we talking clinical, like sort of young people experiencing mental illness, or is think general population, or?
More general mental health population, not clinical.
Yeah. Yeah, so I guess the key thing, I think they both work. Both can be really useful, but I think we need options available. So if we just have group-based, then I think people that may be at risk are less likely to engage, or they're going to need extra support in order to feel comfortable to engage. I think there's a long way that we can go to make the informal sport and physical activity sectors safer, psychologically, culturally safer for people. That would go a long way to probably actually catching a lot. If we just have that one-on-one, I think there is a risk of over-medicalising and over-complicating this stuff. Coming back to the key thing of enjoyment, we've got to make it fun or else they're not going to come. I think definitely in Australia we've made lots of progress with the sort of clinical exercise physiology approach. It goes too far though when you've got someone with a white jacket and a clipboard standing in some front line on a bike. I mean, that will work for some people. Older adults, that might be great. Younger people, we need to think about other ways. But that's where I think also just trying to flip that idea about we don't always need sport, physical activity in mental health services. We can put the mental health services where these people are, meet them there, embed them. Yeah.
Nothing else? No? All right, Simon, thank you very much for coming through. It's awesome. Before I let you go, though, I'd like to just say thanks very much to Vinko for organising this, because without having it professionally done, it wouldn't have happened very well. So thank you very much, Vinko. I'd also like to thank Justin for outing his bromance with Simon to bring him over. So it's wonderful to see. But Simon, that was fascinating. Don't forget, everyone, next month we've got Adrian coming through too, so that's awesome. I'll just close off with a karakia for karakia whakamutunga. Kia mutu a mātou mō tēnei wā, manakitia mai mātou katoa, o mātou hoa, o mātou whānau, ki te aorangi Māori ora. Kia ora. Thank you.
Thank you. All right. Thanks a lot. Thanks for having me.